My name's Khoi Than. I'm a spine surgeon at Duke in North Carolina. So this is a patient that I saw in my clinic who came in to me, a 55-year-old woman with bilateral hand numbness. So maybe starting with Burke, maybe you can talk about, what else do you want to know about this patient's history?
Has she ever had a problem with her cervical spine, like a strain, sprain, any previous injuries? And does she have any neurological additional symptoms in her history, maybe?
Mm-hmm. Yep, those are all great things. So, one thing I learned when I was on the wards is as soon as I meet a patient, I always just kind of ask a very open-ended question. So basically, I say, what's bringing you here? And then, tell me the story of how this came to be. I found that to be a really good strategy for sort of, patients to automatically tell you sort of the, pertinent positives, pertinent negatives, rather than, sort of getting pigeonholed with, very, very specific questions. So I encourage you guys to maybe try that and see if it's beneficial for your interactions with patients. Now, sometimes patients go on completely, wild tangents that have nothing to do with what they're there to see you for, and in those cases, it's very important to, get them focused. But I think you're right on point, Burke. So really important to ask those questions. So I have them tell me their story, right? And so her story was that, her symptoms had been present for 1 year. So obviously very important to understand the duration. Someone who's had symptoms for 1 week, is probably going to be, less, urgent than someone who's had patient for, years, okay? Her symptoms affected all fingers all the time in her own words, and she described them as electrical shocks. I always have them have patients, tell me, how would you describe, your pains in your own words? Sometimes, it's an expletive, which you probably can't put in your, your formal medical documentation. But hers were, electrical shocks, in her arms, worse with coughing. Divine, do you know what that's called when someone kind of has symptoms worse with, coughing or turning their head or?
No idea.
That's okay. Yeah, it's a kind of a read my mind question. So the two sort of things to look for or maybe ask is, if patients sort of get these zaps down their extremities with, bending their neck or extending their neck, that's called a Lehermitz sign. And if they kind of get these symptoms with sort of turning their head and, extending their head, that's called a Sperling maneuver. Those are actually some things that you can test in clinic to see if the patients say, oh yeah, that definitely makes, my symptoms, worse. She also had some symptoms of bowel and bladder urgency. She had issues with gait imbalance, leg weakness, and left shoulder and forearm pain, although those symptoms were now improved. And also really important to ask patients, what makes your symptoms better? What makes your symptoms worse? She did not really acknowledge any specific alleviating or exacerbating factors. So Addie, if you were to, I know you're very early in your training, but if you were sort of to maybe try to localize this, as we like to do in the neurosciences, where would you maybe guess that this patient's symptoms might be?
So with the fingers, with the hand numbness, it makes me think like upper to mid cervical, but then I don't know how exactly the bowel and bladder would play into it. I don't know if it's continuous or maybe it's like metastatic issues that are causing multiple spinal level problems.
Yeah.
And then you also have leg weakness. I don't know if it's like throughout the spinal cord or if it's just like localized edema that's causing these other issues.
Yeah, you're thinking about this exactly correctly. So what I tell patients is that, the spine controls everything below, okay? So if you have if you can imagine there's a spinal cord, nerve roots exiting out, right? If you have something pressing on just a nerve root, then you're just going to have, that nerve root issue. So, let's say you have a C5 to C6 disc herniation. just pressing on the C6 nerve. Well, that's just going to cause kind of maybe shooting pain, numbness, tingling, whatever in a C6 dermatome, which is generally kind of shooting into your, biceps and then into your thumb, right? If you have something pressing on your spinal cord, well, the spinal cord carries all the nerves. And so that can affect not only your arms, but also your legs. And specifically with, cervical myelopathy, that can affect your arms, your legs, and your bowel and bladder. Those are all the questions to ask when someone comes in with what you think is a possible cervical issue, as you've identified absolutely correctly, is, do you have trouble using your hands? You want to ask them, do you have trouble buttoning your shirt, opening jars, etc.? Do you have troubles with walking, right? Do you have any changes in your bowel or bladder habits? And if they do have severe spinal cord compression, then that's going to be, issues with urinary incontinence, bowel incontinence, etc. So to answer your question, yes, something in the neck absolutely can affect your legs, your bowel, your bladder. And I think as you get later in your M1 year, you're going to learn more about upper motor neuron versus lower motor neuron signs. And generally, spinal cord compression will cause upper motor neuron signs with weakness, atrophy, bowel bladder issues, hyperreflexia, etc. Okay. So Alexandra, kind of after you worked through the chief complaint and the history of present illness, what are some other really important things to learn about in the patient's history?
So of course, if there was any past history of cancer or injury, of past surgeries, infections, any vascular deficiencies that could have happened somewhere else, and I don't know, I'm thinking like any type of tumor.
Mm-hmm.
Yeah,
very good. So the components of the history and physical are chief complaint, history of present illness. As you've touched upon, you really want to know about the past medical history, the past surgical history. Oftentimes patients may not remember to tell you everything there, so then you want to look at their medicines and, for example, ask them, why are you taking aspirin, or, why are you on Coumadin? Things that are important, especially as you get closer to, surgical decision making. Allergies, of course, then family history and social history. And I think for a spine surgeon specifically, the social history is particularly important. Specifically, whether patients smoke, because that can really impact their healing after surgery. And I would encourage, as you get into your own practices down the road, just really to learn a little bit about patients, what they do for a living, what their hobbies are. In this day and age, patient ratings and whatnot are very highly publicized, and I think if you take a couple of minutes to really learn about patients and their hobbies, shows them that you are interested in more than just their problem, and also may help your relationships with them. Let's say you both happen to like baking, like this patient did. Okay, so her past medical history was, I would say, by and large, not pertinent. Certainly for diabetes, you want to know how well that's controlled and what their hemoglobin A1C is. Generally, anything above 7.5 or 8 can portend a worse prognosis if they do need surgery. So you'd want them to get that under control prior to any intervention. She did not really have any pertinent past surgical history. Medicines were appropriate to her past medical history. And then for her social history, she worked as a medical transcriptionist, loved to bake, and was not a smoker. So let's talk about the neurologic exam. Burke, what are the important, or actually, what are the components of a neurologic exam?
In this patient, we need to do a full neurological exam. So we need to check from her cranial nerves to deep tendon reflexes, and see see if there are any abnormalities within the whole neurological spectrum. We can expect to see some numbness, as also stated in her symptoms, in her upper extremities, and also some loss of some force, in her upper extremities. Yeah, so we just can't let this patient go without a full neurological exam.
You're absolutely right. So, I always think about it very sort of methodically. And when I'm seeing a new patient, at least, and even though I'm a spine surgeon, I still check a full neurologic exam. So the way I think about it is, mental status. Usually for spinal disorders, you don't need to get into, the full mini mental status exam or anything like that. But, just make note of whether they're awake, alert, and fully conversant. Then I usually do a cranial nerve check. I usually don't check number 1, but do some sort of assessment of 2 through 12, which can be done, pretty quickly. For a spine surgeon, the most important part of the exam certainly is the motor exam. So I check their strength, always the same way. So I see if they have a pronator drift, although that's usually more for brain pathology. Then I'll check their, hand grip, biceps, triceps, deltoids, hip flexors, hamstrings, quadriceps, tibialis anterior, gastrocnemius muscles. And if I'm specifically interested in L4 to L5, then I'll check their extensor hallucis longus muscles as well. Now, people can do a very, very thorough sensory examination with like pinprick and vibration and temperature and whatnot. I can't say that I've ever, made a surgical decision based on a sensory exam alone. So I kind of just do a haphazard, light touch examination. Although when you guys rotate on neurology, you'll see that they spend a lot of time on, vibration and all the other sensory modalities to help with their localization. Reflexes tend to be pretty important as well. So again, I kind of just check for evidence of, spinal cord pathology and upper motor neuron signs. So a Hoffman reflex. Do you guys know what a Hoffman sign is? Yeah. So essentially, if you rest the patient's hand in yours and you flick their middle finger, if their thumb beats in, that's actually a sign for upper motor neuron disease, very much similarly to a Babinski sign or ankle clonus. So that tends to be a quicker way to assess for hyperreflexia than whipping out a reflex hammer and doing all the deep tendon reflexes. I'll also test their coordination, mostly because it's habit, but it's for cerebellar pathology. And then really important to assess for gait as well. So regular gait, toe gait, heel gait, tandem gait. Now tandem gait is going to be best for understanding balance, but with your toe gait and your heel gait, you're going to be able to assess for specifically S1 and L5 pathology specifically. This patient had a completely normal exam with full strength, no abnormal reflexes, and a normal gait. So before we jump into imaging, do you guys have any questions about the history and the physical? All right, so Divine, very important is to also ask for spine patients what they've tried for their pain, okay? So if someone comes in and says, I've got neck pain that had started yesterday, just neck pain, no other symptoms, and I haven't tried anything. So no medicines, no physical therapy, no injections or anything like that. That's someone that I won't say everyone, but I think for ethical physicians like you guys, that's not going to be someone that you rush to surgery the next day. Neck pain and back pain are super common. It's estimated that 80% of the population will have neck pain or back pain at some point in their lives. I think that's probably actually an underestimate. And most people will get better without surgery. So it's really important to ask patients, what they've tried. And, I think this patient had tried a number of things. So Divine, what sort of imaging studies do you want to get on this patient who has the symptoms she has and she's tried, a few forms of non-operative therapy?
So just, I guess, looking at the occupation of the patient and sort of looking at the numbness bilaterally in the hands, perhaps maybe an MRI, or you could also use an ultrasound to look to see if there are any impingement in the flexural retinaculum.
Very good. Very good. Yeah, I like that you've thought about the peripheral nervous system. You know, certainly if someone came in without her bladder symptoms, kind of complaining of fingers and complaining of numbness in her fingers, would definitely think about peripheral neuropathy, specifically carpal tunnel syndrome or ulnar neuropathy. Now, what about this patient, Divine, would make you less likely to think peripheral neuropathy, given that all fingers are involved?
The fact that I guess like her history sort of shows like beyond just like hands, you see a lot of bladder issues too as well.
Yeah, I guess what I'm getting at is with carpal tunnel syndrome, which is super common, you would basically expect only these three fingers involved.
Oh yeah, because it's the median nerve.
Yep. And which nerve affects these two?
Ulnar.
Yep. And where is that usually compressed, if there's a compression?
Guillen's canal.
Guillen's canal is one point of compression, which is closer to the hand, but it's usually in the cubital tunnel in the elbow.
Usually with more exposed, yeah.
Say that again?
Oh, sorry. I was like, yeah.
Yeah. So someone who kind of complains of all fingers usually is not peripheral nerve, although you certainly see people with both carpal tunnel and ulnar nerve. But generally, the best study for that, I like your idea of the ultrasound, but the best study for that to evaluate between peripheral neuropathies is going to be usually an EMG. So basically, they put needles into different muscles, measure the nerve conduction, and are able to tell if the issue is peripheral or radicular. But I like your idea of an MRI. In fact, that's the next slide. So Addie, again, I know you're an M1, but what do you see here?
Well, it looks like there's impingement on the spinal cord in the cervical level. It looks like the disc is bulging backwards and kind of compressing.
Yeah, you're absolutely right.
And I remember learning that 1, 2, 3, 4, C3-4.
Close, and this confused me as well. But don't forget that C1 is just a ring that sits on the big C2. Okay, so this big bone there, if you can see my pointer, is C2, and this little one is C1. Okay, and that's 3, 4, C4, 5.
Okay.
So you're absolutely right. And Alexandra, what do you see anything else here?
Well, this is T1 image, I think, or maybe flare. How would you distinguish between T1 and flare?
It's a great question. So the way I always think about it is T2 makes the H2O, or the water, bright. And so on sequences where the CSF is bright, those are T2. Maybe that's a long, sort of a long way to think about it, but that's how I always remembered it. And then with T1, then the CSF is black. Okay. So yeah, I think it's always, yep, that's right. So I think it's always good to be very methodical about how you read these. Okay. So when you guys are on the wards and someone pops up an MRI and they say, interpret this, you just want to start with the basics. So the way I would read this is that, this is a sagittal T2 weighted sequence of the cervical spine. Then you want to comment on alignment. The cervical spine appears reasonably well aligned. Okay. Then you want to talk about the talk about the disc spaces. All right. So you can say that the patient has cervical spondylosis, which is a very vague term for disc herniations. And this is most at C4 to C5, like Addie mentioned, okay, where there's severe spinal cord stenosis. And I think what you can also appreciate here is that in the spinal cord, there's a little bit of different color, right? At C4-5, the color looks a little bit different compared to the rest of the spinal cord. And so that can be caused, you can call that myelomalacia, you can call that, spinal cord contusion, or what have you. So that's kind of basically how I would go about reading these. Now, it's really important, guys, that not only the sagittal sequence is looked at, but you have to look at the axials, right? The axials are actually a much better way to assess the amount of compression. And also, they'll give you a good idea not only of central compression, but also foraminal compression, okay? So here at C4 to C5, like Addie mentioned, you see this big sort of central disc herniation, right? Clear compression of the spinal cord there. But you also see at C5 to C6, which on the previous slide, was less impressive, because C4-5 is way more impressive. You also see that that's indenting the spinal cord as well. There's stenosis there. And also at C6, C7. So very, very important to look at the axials. Interestingly, all of her compression is central, and you'll see that the foramen at C4 to C5, C5 to C6, and C6 to C7 are all very free. I just gave away the answer, but Burke, what other imaging studies might you want to get on the patient?
A plain radiography, maybe?
That's right. Plain radiography. And what do you see here, Burke? Anything interesting?
Let me check. I just couldn't identify something specific at the moment. Sorry.
No, that's fine. It's actually pretty unremarkable. On the AP view, you can see, no cervical scoliosis or anything like that. And on the lateral view, Burke, would you say that she has normal cervical lordosis? Does she have cervical kyphosis? Does she have sort of a straightening of her cervical lordosis?
Yeah, she seems that she has lost her lordosis on the cervical spine. Yeah, it's just, it shouldn't be this much straight.
That's that's more or less true. So the cervical spine is normally lordotic, but I think what we would consider normal is anywhere between 10 degrees of lordosis and 10 degrees of kyphosis. So if I see someone with a straight neck, I'm usually not super worried, okay? Because having a little bit of kyphosis is actually within the realm of what we would consider normal. All right. If we're being really nitpicky here, if you really kind of look closely at these disc spaces, what you'll see here is a little bit of osteophytic change there at C4 to C5, C5 to C6, C6 to C7. You see how those little bone spurs are all there?
Yeah.
So that's something that, as you look a little more closely at these, you might pick up on as well. And the workup of cervical spine patients, I get flexion extension filmed as well. Especially if they have neck pain, you want to see if there's anything moving abnormally in their alignment. And what you see here is that when she flexes her neck forward and when she flexes her neck backward, there's no real abnormal motion there. Okay, so this patient has a cervical myelopathy, mostly from C4 to C5, but who knows, maybe also a bit from C5 to C6. C6 to C7. Divine, what do you want to do for this lady?
Just, I guess, taking a stab at it, yeah. Well, since she has a disc impingement, maybe do a discectomy.
Mm-hmm. And would you do one level? Would you do 2 levels? Would you do 3 levels?
2 levels.
Which 2?
4 to 5.
Okay, so important to point. So C4-5 is, that disc is going to be considered 1 level.
Okay.
And then C5-6 would be another level, and C6-7. Okay. So you would do 1 level then?
Yeah, 1 level.
Okay. And so you do a C4 to C5 discectomy.
Mm-hmm.
And would you do this from the front or from the back?
From the back.
From the back. All right, let's talk a little bit about that, okay?
Yeah.
All right, so the reason why it took the Duke Spine faculty an hour to talk about this case is because there's a lot of ways to go about it, okay? And then I'm going to present you guys with a series of questions here. So the plan here, do we go front or do we go back? So for the lumbar spine, where there is usually no spinal cord, doing discectomies from the back is fine, because when you retract the neural elements, you know, you're not really going to cause a problem, right? If you do a discectomy from the back and you have to retract on the spinal cord, that can actually really injure a patient. Now, if the disc herniation was more laterally out into a foramen and pressing on a nerve root, then a cervical foraminotomy from the back with a discectomy is absolutely reasonable. With her disc herniations being more centrally located, you know, a discectomy from the back is going to be harder and also, you know, potentially more dangerous to the patient. Okay, so I would argue doing this from the front, although from the back you could certainly consider just doing a laminectomy, and that would decompress the spinal cord, but without doing a discectomy, just because, again, it's going to be hard to remove the discs because the spinal cord is going to be in the way. All right, so if you do this from the front, definitely a discectomy. If you do it from the back, probably a laminectomy with or without a fusion, or with a technique called a laminoplasty. All right. So, Addie, how many levels? Are you going to be, you know, 1, 2, or 3 level?
Like based on the imaging and my lack of knowledge, I would say maybe C4, 5, and then 5, 6. So 2 levels.
Because you thought 6, 7 was maybe less impressive?
I think.
Yeah, that's fine. So it's a real question, right? How I would come to this decision is I would ask the patient, right? So the conversation I had with her is, you know, obviously, you know, your symptoms are probably mostly coming from this huge disc herniation at C4 to C5. That being said, you do have some disc bulges that are, you know, not insignificant at C5, 6, and C6, 7 as well. So, you know, our options are we can just treat one level and see how that goes. There's a chance that, you know, you wake up and you still have some symptoms because, you know, C5, 6, and C6, 7 are compressive. Or we do a bigger surgery, which comes with the risks of a bigger surgery, you know, but you wake up and we've addressed all the pathological levels. You know, which one do you want? Okay, so, you know, I think oftentimes as surgeons, we may try to choose the surgeries for patients, whereas usually, at least with spine, which is one reason why I really love spine surgery, there's a spectrum of options, and you present them to the patients, and you see kind of which one they're more sort of in tune with. Let's see, Alexandra, fusion or arthroplasty?
So arthroplasty is when you replace the disc with bone?
So fusion is when you replace a disc with bone, and arthroplasty is when you replace a disc with an artificial device. And so this is kind of more of like a resident or fellow level question, actually. So we'll just talk a little bit about it. In some, and you know, if you guys follow the Virtual Global Spine Conference, Dr. Rasuli gave a great talk on arthroplasty. But ACDF is tried and true. It's been around since like the 40s or 50s. You take out the disc, you put a piece of bone there. If you want to, you cover it with a plate and some screws, and that heals over time. Okay. Arthroplasty, it's actually a very similar procedure because you're taking out the disc, freeing up the neural elements, but you're putting in an artificial device. Now, the data on artificial devices is only about 10 or 12 years old. Okay. The data on shoulders and hips is much more robust. And I think even if you see a hip or a shoulder doctor, they're going to tell you that your device will last for about 20 years. So I think we're entering a decade where how effective the cervical arthroplasty devices are in the long term will be really interesting. But the theoretical advantages with arthroplasty are that you maintain your range of motion in your neck, and therefore you lower the risk of adjacent segment disease. So when you fuse the spine, it'll put greater stress at the adjacent levels. So you may do C4 to C5 ACDF, and this patient might come back down the road with problems at C3 to C4. Okay, that's and also important to note that arthroplasty, at least FDA, is only approved for 1 or 2 levels. So if you treated this patient with 3 levels, you'd probably just do a fusion, or you could do a sort of hybrid construct where you fuse 1 level and arthroplasty 2 levels. Okay. Right side or left side, Burke. If you do, let's say you try to treat this anteriorly, do you go from the right or the left, and why?
I'm not sure about that. Yeah, I don't know.
That's okay. It's all surgeon preference, right?
Probably because it's probably because we gotta think about the adjacent anatomical structures, the nerves and the vessels. But I'm sure that this decision has to be made according to the anatomical things that we need to consider, but I'm not sure which one would be a better choice.
Yeah, you're absolutely right. So usually if people are thinking about the anatomy and they want to take that into consideration here, they're usually going to approach an ACDF from the left. And the reason why that is because the course of the recurrent laryngeal nerve, which controls our vocal cords, is more predictable on the left side compared to the right side. That being said, no study has ever shown increased rate of injury to the recurrent laryngeal nerve with a right-sided approach, and therefore many people, myself included, will prefer a right-sided approach because I'm a right-handed surgeon, and therefore it's going to be more efficient to do this from the right. Others might address the surgery on the side opposite to where the symptoms are more prevalent, because it'll be easier to reach the opposite side with your surgical instruments. Okay, it's been great chatting with you all. I think we're getting ready to switch rooms, but I treated this patient with a 3-level ACDF, and she was so happy she baked me some cookies. All right. I hope you guys, if you choose to do neurosurgery, that you choose to look at Duke. It's a great training program here, and we'd love to have you.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.